We're going to switch gears for a few moments. I have two cases I presented, go from plumbing to electricity. These will be general medicine cases that would be of interest to everybody, I think. Here are my disclosures. So this is a woman who comes for preoperative evaluation prior to thoracic surgery. She comes for clearance by the thoracic surgeon. She's got a bronchogenic cyst that the thoracic surgeon has recommended surgical resection. She's got a history of hypertension, no cardiovascular complaints, no history of syncope, pre-syncope. No pertinent family history, no history of sudden death in the family. She works as a high-power attorney, non-smoker, exercises regularly without limitation. Her medicines are amlodipine and nalopril for her hypertension. She takes Vyvanse, 20 milligrams a day. Exam is benign, labs are unremarkable. And this is her electrocardiogram in the office for preoperative clearance. Anybody from the audience want to make some comments? So she's here for routine preoperative clearance, no complaints. Long QT. The QT is a little long, so the computer says 492, 507 corrected. So any preoperative or perioperative concerns or recommendations to our thoracic surgeon, what would you guys do? What do you think? So the QTC is 507, obviously. She's asymptomatic. And the question is, does this 58-year-old woman have long QT syndrome? Is it acquired or congenital? Anybody from the audience want to say anything?
Hey, Bruce, can you go back to our meds again? I know.
Sure.
So this is a loaded case because it's an ED guy.
Those are her meds. Anybody want to stop the Vyvanse and repeat the ECG? Yeah, okay. So the question is, does she have long QT syndrome? This is the consensus recommendations from HRS, Heart Rhythm Society, if you don't know, whether or not the diagnosis of long QT syndrome can be entertained. First of all, if you have an unequivocal pathogenic long QT gene mutation, then you have the diagnosis, obviously. If you have a QTC more than 500 milliseconds on repeated ECGs, well, we have one ECG. So in this lady, we go back to her family medicine physician internist, and we pull up an old ECG 4 months earlier, and her QTC is 487 here. So we don't quite make the diagnosis yet of long QT syndrome because we have one ECG with 507 milliseconds and one ECG 487 milliseconds. And then you ask yourself, what about the long QT syndrome score? Well, this is a score basically from Peter Schwartz from Italy from the 1980s. It's a very old scoring system prior to genetic testing, but it looks at clinical risk factors, and the importance of it is that even if you have an ECG showing a long QT, you don't get the diagnosis of long QT syndrome without something else. You got to have some other clinical tidbit to hang the head on because high probability is 3.5 points. So is there a clinical history of syncope? Is there a family history of long QT syndrome or a family history of unexplained sudden death in somebody under age 30? Is there congenital deafness? Or there's other interesting ECG abnormality, T-wave alternans, or does the QT fail to shorten with exercise? The QT should normally shorten at higher heart rates due to the effects of adrenaline, and if it doesn't shorten during recovery at the 4th minute of recovery, this gives you an extra point. So 3 points for a QTC greater than 480, and 1 extra point if it's more than 480 at the 4th minute of recovery. So we put her on a treadmill, and here at 3 minutes and 50 seconds, her QT measured either in lead 2 or V5, which are the preferred leads, is 542. So we have the diagnosis of long QT syndrome because she gets 4 points. 3 points for the one ECG showing a QT over 480, and 1 point for fail to shorten the QTC with exercise. So the question then becomes, she's sitting in the office, wants to undergo her thoracic procedure. Should you do genetic testing in this patient? Any comments? You're not going to get the results back before her surgery, but would anybody do genetic testing in a 58-year-old woman?
She's a high-powered attorney.
High-powered attorney. With 2 children, 2 sons, who are also on Vyvanse by her report. So Stan, does that mean you want to do genetic testing?
I'd ask you.
Well, actually, exactly. So the guidelines say it's a class 1 recommendation that we should be doing genetic testing. It is recommended in someone who a cardiologist thinks there's a strong suspicion of long QT syndrome, or that there's ECGs showing a QTC over 500 milliseconds. Even in an asymptomatic patient, it's recommended genetic testing in these patients. So what are we looking for in genetic testing? Well, there's now actually 16 genes identified. This is an older slide, but back then there were 12, but it's predominantly 3 genetic mutations, LQT1, 2, and 3, and 90% of the genetic mutations in long QT syndrome are accounted for by LQT1 and 2. LQT1 is the IKS mutation. IKS is the slowly rectifying potassium channel that activates at higher heart rates during catecholamine stimulation, and LQT2 is the IKR genetic defect. In the old days, before we had genetic testing, the ECG gurus used to be able to look at the ECG and predict which was the genetic or the potassium channel or sodium channel mutation, because there were certain patterns that fell out as consistent with a particular genetic mutation. That was subsequently verified in the days of genetic testing. In the Mark Keating identified the potassium channel gene around 1990. So LQT1 classically has a prolonged QT with normal proportions to the T wave. LQT2 often has bifid T waves, as you can see. Often the patients have sinus bradycardia. And LQT3 has a very longish ST segment here. So if you go back to this lady's ECG, both on the left at rest and with exercise, what do you think this lady has? 1, I see. So she likely has LQT1. And in fact, we do genetic testing, and she's got a pathogenic variant in the KCNQ1 gene due to a missense mutation with the substitution of proline for leucine, and this is expected to produce the LQT1. So she's an asymptomatic 58-year-old woman coming in for preoperative clearance. Do you let her have her surgery? Yes, I think you can clear her for surgery, and then you recommend genetic testing. It's also a class 1 recommendation that family members undergo mutation-specific genetic testing. You've identified her as the proband. You know what her mutation is, and it's recommended that family members also undergo screening. So what is the probability that each of her 2 children, 1 daughter and 1 son, she actually has 1 daughter, I said 2 sons, she has 1 daughter and 1 son, will have inherited the LQT disease susceptibility genetic mutation. Not that they necessarily have the phenotype, but what's the probability that they've inherited genetic mutation? 0%, 25%, 50%, 75%, or 100%?
Is it autosomal dominant?
Thank you, Stan. It's autosomal dominant, and females and males are genetically equally affected. So there's a 50% chance that each child has inherited the genetic mutation. And genetic testing is recommended, as well as attention to electrolytes and the like, avoidance of certain drugs. I give my patients this website that used to be called longqtdrugs.org. It's now called crediblemeds.org. I keep it on my phone and can look up drugs at any time that I'm sure most of you are familiar with. But it is useful, and you'd be amazing. The list changes. I get emails almost once a week from Ray Woosley about new drugs that are added. It's impossible to keep the list. But one of the drugs, if you plug it in at the website, is that Vyvanse, which she says she has to take in order to function in the courtroom as an attorney. She's a prosecuting attorney in Atlanta and insists that she take this drug. And the issue is that it's a drug that's contraindicated in long QT syndrome. It's basically giving somebody a catecholamine stimulate, and you have to recommend that she no longer takes it. If you plug it in, it's clearly a drug to be avoided in the congenital long QT syndrome. So we make her stop the Vyvanse, And here's her ECG off Vyvanse. The QT is still long. No surprise. You wouldn't expect the Vyvanse would alter the QT, but it's giving somebody adrenaline in that sense, and you have to advise that she stop it. You also want to advise the anesthesiologist and the surgeon that there are certain culprits to avoid in the perioperative setting. Zofran is a particular culprit that we see often to be aware of, that we see cases of torsade, but just something to be aware of in the back of your mind in practicing good medicine. The next question is, should this patient be treated with a beta blocker or receive a defibrillator? 58-year-old attorney, asymptomatic. I see shaking heads no. Would you give her a beta blocker? Anybody want to venture a guess? No one. Okay, yeah, the guidelines actually say she should definitely take a beta blocker. This is a class 1 recommendation. Beta blockers are recommended even in asymptomatic patients with a QTC greater than 470 milliseconds. And which beta blocker would you prescribe? Does it matter? Does it matter? Anybody, does it matter what beta blocker you prescribe? Actually, it matters quite a bit. There's very strong evidence that the first two are ineffective in the inherited arrhythmia syndromes. Atenolol and metoprolol should not be used in CPVT, catecholaminergic polymorphic VT, as well as in long QT syndrome. There's very good evidence that nadolol is the best, although it's an older beta blocker. It's very good evidence from multiple authors and multiple institutions that nadolol is the preferred beta blocker to give these patients, and avoid atenolol and metoprolol. There clearly have been events, syncope or sudden deaths in long QT syndrome patients treated with metoprolol, toprol, or atenolol. In kids, we often give propranolol.
Why is that?
There's a number of potential mechanisms. One is thought that it's very long-acting. So in kids especially who are not compliant, if they miss a dose, the very long-acting nature of the drug, it also has a minor class 1 effect, a class 1 antiarrhythmic effect, and can actually shorten the QT. What we do often is put these patients back on a treadmill and look at their QT with exercise. So nadolol has been shown to shorten the QT with exercise, whereas atenolol and metoprolol do not.
That's been shown to prolong life.
That's very hard to do, survive, because this is actually pretty rare, but it's been shown to prevent syncope in these patients. So there's never been a mortality study in any inherited arrhythmia syndrome, and probably never will be in any of these syndromes because they're so rare and difficult and the events are pretty low. What about an ICD? Would you give her an ICD? No, an ICD is actually contraindicated in this setting. An ICD should not be implanted in asymptomatic long QT syndrome patients unless they've been on a beta blocker. What about her age? Does that have any implication? She's 58 years old. She actually refused the beta blocker, despite me trying to talk to her repeatedly. She agreed to stop the Vyvanse, but she refused to take a beta blocker. She says, what's that?
A neighbor told her something.
Exactly. I've read about all the side effects of beta blockers. I've lived 58 years. I'll be fine. And actually, so I said, this is probably a relatively benign mutation. You have lived 58 years, but the truth is she remains at high risk for sudden death. If you look at the long QT syndrome database, there's a 2.5-fold increased risk of sudden death in the 40 to 60-year-old age group, especially in females, as you can see here. So you can see on the left here, I don't have a pointer, but on the left, in the 40 to 60-year-old age group, there's a 2.5-fold increased risk of sudden death in long QT syndrome patients over the age of 40, not seen in males. In males, the high-risk period is the prepubescent period. Young men with long QT syndrome are very high risk of sudden death. Females over the age of 40, a QT over 500 especially is a very, very high-risk marker. She comes back 6 months later to me and says, I want to run in the Peachtree Road Race next week. It's next week, but she came back to me and see me in January. I want to run in the road race. Is it safe? She's an attorney, a prosecuting attorney. Stan, what do you tell her? And right next to my house, right? As you know. You get off easy in the audience because the guidelines say you got to refer the patient to answer this question to an expert for evaluation. So the first answer you all gave was right. Send it to an electrophysiologist. So the guidelines actually say if a long QT patient wants to engage in competitive or high-level exercise, the patient should be referred to a clinical expert, and you can deem who you consider a clinical expert for evaluation. In difficult patients, I often send them to Michael Ackerman at the Mayo Clinic, who has a tremendous amount of experience with these very rare syndromes. But in general, the guidelines say that patients with long QT syndrome can participate in athletic activity. There was a recent guideline published in Circulation for an athlete with a long QT over 470 in a male or 480 in a female who is asymptomatic on treatment. Competitive sports can be permitted providing they take the following precautions. They understand the risks. There's people jump out of airplanes, do crazy things. As long as they understand the risk, avoid QT prolonging drugs, and it's recommended that these patients obtain a personal AED and their family members or coaches or whoever are available and understand how to use the AED. So those are the guidelines. Interesting case. And there's also a very strong association in long QT patients with swimming. The classic event is sudden death during swimming. If you get a family history that some young family member drowned, especially at a young age, you've got to think immediately that there's long QT, LQT1 in the family. That's a very important clinical pearl to remember. Drowning is LQT1 until proved otherwise.
And is it the rhythmic movement of the arms? What is it? What is it that...
No one knows. I don't think anybody knows. I mean, people have drowned not even actually swimming, but in water and just drown. I don't know. No one knows why it is, but that's the classic events. I mean, LQT2, the classic thing is the doorbell rings and the patient has a cardiac arrest. You know, there's certain events that we trigger. Do I have time for a second case? Yeah, well, the race is July 4th, so yes, I said she could run. She refused the beta blocker at this point, although I had the discussion with her in considerable detail.
Yeah, I think we only have 3 cases left, so...
So she's going to have somebody carry an AED for her? Chasing after her?
And her son and daughter have both refused genetic testing in their 20s and 30s.
They should run together with her. Yeah.
And are on Vyvanse. Yes, there's a question.
Someday we'll have CRISPR technology to fix this, right?
Sure. Genetic therapies, I think, certainly in the future, certainly be available, but not for the foreseeable future. So this is another young patient with an arrhythmic syndrome sent to me. This is a very interesting and informative case for me. So busy day in clinic, 20-year-old, healthy male comes into my office with his mother. He's ready to go back to college at University of Georgia, and the complaint is that the pediatrician hears an irregular heartbeat on auscultation, on exam, and is sent to me as an electrophysiologist, the pediatrician. So patient says he's totally asymptomatic. He's in August, he's getting ready to go back to school. He's in the summer, he's got no history of any complaints whatsoever, no past medical history, and he's an active college student. He claims he doesn't use alcohol, no recreational drugs, family history is non-contributory, he has no siblings, he's on no meds. His exam is unremarkable except for premature beats, which you can clearly auscultate, which the pediatrician picked up and referred him to an electrophysiologist for this problem. He does have very massively enlarged calf muscles bilaterally. If anybody is very astute, you'll pick up the diagnosis. Here's his ECG in the office. So it's benign except for a single PAC, a premature atrial contraction. You see on the second beat there, likely coming from the inferior left atrium or the coronary sinus. The P wave is negative in the inferior leads. The PR interval is a little shortish, 108 milliseconds. And otherwise, I mean, I can't lay my hat on anything on this ECG. Anybody else want to make any comments about the electrocardiogram in the office? A Q in V2. I don't think that's quite a diagnostic queue, but there's a micro queue, I'd call it. It's not, I don't think it's quite 40 milliseconds. So, Stan, what would you do, since no one else is willing to volunteer? Would you do any testing, or a Holter, an echocardiogram, an exercise treadmill test, cardiac MRI, routine labs, genetic testing again, like the last case? Or no testing is indicated, simply reassure the mother and the patient he's fine, go back to college, nothing to worry about. He's got an irregular heartbeat picked up again by the pediatrician and PACs on the electrocardiogram. Anything, Stan?
I mean, he had a good deal of voltage, which an athletic, thin young man might be normal, and that infralateral T-wave
Yeah.
that could be used. So, but I'd probably be an echo guy.
Yeah, I think that's reasonable. Do an echo. And I said, quote, to the mother, literally, this is a quote which I'll live forever down. There's a 99.9% chance the echo will be normal. Yeah. So I'm in Paris the next week, and my nurse calls me saying, this is what the echo shows. He's got an ejection fraction of 35 to 40%. The ventricle is dilated in his hypokinesis. My colleague, Dr. Burkle, who I saw here earlier, read the echo, actually, in this young man. So what do you do now? What test would you order next to evaluate this newly detected asymptomatic cardiomyopathy? Would you do a Holter? Remember, he's got frequent PACs. Would you do a stress test, a cardiac MRI, a routine chemistries, or would you do, again, genetic testing? A stress test, I heard? Not unreasonable. I did a Holter and a stress test. So I did a Holter, and he's got pretty frequent PACs. He's got almost 13,000 PACs a day, some short runs of SVT. One of the examples shown here at the bottom, 4 beats at a relatively slow rate, no AF, no SVT, no ventricular arrhythmias. He's got 2 PVCs. But the kid said he was totally asymptomatic, but so I put him on a treadmill just to assess his functional capacity. It was actually quite impaired. He only was able to go 7 minutes on a Bruce protocol, 7.3 METs, and he stopped because of lower extremity weakness. And there's his sinus tachycardia at the end of exercise. So he's impaired, despite him saying he doesn't have any complaints. He clearly doesn't have the functional capacity of a healthy 21-year-old that you would expect. So what do you do next? So this is a 21-year-old with a newly diagnosed cardiomyopathy. Cardiac cath. We heard about the plumbing. Anybody want to cath him to look for a congenital anomaly? Cardiac MRI. Anybody want to do a biopsy? Chemistries, genetic testing. Testing not indicated. Was that? TSH. Okay, so I did routine labs, and this is what it came back. All the labs are normal except the CPK was 2666. I repeated it, and it came out to 6,180, and repeated it again. It came out 2,627. The kid insisted he doesn't take anabolic steroids, doesn't do any drugs. His mother says he's the most boring kid you've ever met in your life. But his CPK is elevated. He's got some elevated transaminases as well. Did a chest x-ray, which was relatively normal. He's got some scoliosis. Tox screen was negative. BNP was practically 0, 3.8, and troponin was negative. Anybody have any thoughts now? What's going on? Muscular dystrophy. Very good, very good. So newly diagnosed cardiomyopathy. He's asymptomatic. He's got frequent PACs. He's got an elevated CPK, and he's got liver transaminases that are elevated. What would you do next? Well, to make it quick, I did a cardiac MRI, and no scar. You're looking for fibrosis in these because it's going to be a muscular dystrophy case. But oftentimes you'll see fibrosis, particularly of the posterior and lateral wall, the basal wall there. But he had no fibrosis. And at that point, I elected to put him on an ACE inhibitor, a beta blocker, and sent off genetic testing, which came back positive for a Duchenne muscular dystrophy genetic mutation. This is a Becker's phenotype, in that the Duchenne patients typically are the kids in the wheelchairs with muscular dystrophy because they completely lack dystrophin. The Beckers often can present just like this. They have minimal muscular complaints, these patients, because they have either impaired or a lower level of the dystrophin gene, and therefore functionally the skeletal muscle syndromes are not prominent, although they often have a CK elevation. They often present, as this kid did in their 20s, with a newly diagnosed cardiomyopathy. That's pretty typical with the Becker's muscular dystrophy. There are multiple different types of muscular dystrophies, but this is the Becker's one that clearly can present totally asymptomatic with heart failure, often with atrial arrhythmia is interesting as well. So if you see a young patient with atrial arrhythmias, AF, check a CK as well. Becker's muscular dystrophy is an X-linked recessive inherited disease. It's 3 per 100,000 live births. It's due to the depletion of dystrophin rather than a complete absence. In Duchenne, again, the dystrophin is totally absent, and therefore these kids are often in wheelchairs. It can affect the skeletal muscles, brain, and myocardium. CPK is increased. It often presents as dilated cardiomyopathy with heart failure in males in their 20s. Females who are the carriers do present with this later in life, typically in the 50s, 60s-year-old, and the mother is the carrier typically, so she should get a CPK, and if that's elevated, she should also be tested. Often, again, there's no evident, maybe no symptoms of skeletal muscle disease. They often have this waddling gait, and that's why, because of proximal muscle weakness, and that's why the calves are often hypertrophied in these kids who present this way. There can be rapid progression in males who present with cardiomyopathy, and many of these, it's not that common, but many of these kids will need transplantation in the future years. And atrial and ventricular arrhythmias are often a marker of disease in these patients. The other key point in the muscular dystrophies to note is that if they present with any evidence of AV block, even first-degree AV block, this is an indication for a pacemaker implantation because oftentimes it's progressive. So first-degree AV block in a muscular dystrophy patient warrants pacemaker implantation in the guidelines. And these is his subsequent images after he was treated with an ACE inhibitor and beta blocker, and he's remained asymptomatic in 18 months follow-up, doing well, working on good medical therapy at this point. Thank you for your attention.